This video is going to talk about aortic insufficiency. And if you look at my channel, there are 4 different valvular videos: aortic stenosis, now aortic insufficiency, mitral regurgitation, and mitral stenosis. There are 4 valves in the heart. I don't have any videos specifically discussing tricuspid or pulmonic valves at this point. Tricuspid procedures are becoming more frequent, so I may produce a tricuspid video in the future. But the majority of valve problems that we see in adult cardiology relate to either the aortic valve or the mitral valve. Stenosis refers to a valve that doesn't open well. Insufficiency refers to a valve that doesn't close well. And valves are like doorways. When blood goes from one chamber to the next, the door between those 2 chambers opens to allow blood to go forward. When blood gets pumped in the subsequent chamber, the door that had just opened now closes and the next door opens. In this way, blood sequentially goes through the chambers in the heart in the forward direction and nothing goes backward. So if your cardiologist says that your mitral valve leaks, nothing is leaking out of the heart, it just leaks back into the chamber that it came before. The aortic valve is the last valve that separates the heart from the body. And when people have aortic insufficiency, what that means is blood gets pumped forward and the aortic valve opens, but when the left ventricle, which is the main pumping chamber, finishes pumping, the aortic valve is supposed to close so everything that got pumped out to the body stays in the body, nothing comes back into the left ventricle. With aortic insufficiency, when the arteries, especially the aorta, starts constricting a little bit, that pushes some of the blood backwards into the left ventricle. The worse the aortic insufficiency, the more the heart stretches out over a period of time, and eventually once the heart stretches out enough, it starts to become weaker. The problem with aortic insufficiency is when the heart stretches out over time, eventually it becomes weak. The issue with this is patients tend not to get any symptoms related to aortic insufficiency until the heart is extremely dilated. At that point, even if you fix the aortic valve, it's usually too late for the heart to recover its function. So you can have a normally functioning valve at that point, but at that point the heart can't return to its normal function, and we can't improve the patient's symptoms, oftentimes without either a transplant or what we call mechanical support devices, which would be anything from an artificial heart to other pumps that we put inside patients to try to get more of the blood from the heart out to the body. So with aortic insufficiency, it's important, especially if a physician hears a murmur that's related to this, to get an ultrasound and look to see if the aortic valve is leaking. If it is leaking, the goal of medications is to keep blood pressure lower, because the lower the blood pressure, the less recoil there is pushing blood back into the left ventricle. And with this specific valvular abnormality, we don't like the heart rate being too low, because the lower the heart rate, the more time there is for blood to go from the aorta back into the left ventricle. So these specific patients are the one patient where we actually like the heart rate to be a little on the higher side, and will intentionally choose medications that increase the heart rate a little bit, such as nifedipine, which is a drug which was trialed 25 years ago for one of my former department chairs, Dr. Bonow, which showed that by using this drug, you actually improve aortic insufficiency and decrease the likelihood of somebody needing a valve replaced, or increasing the time to when something needs to get done. But other drugs that also lower blood pressure, that don't lower heart rate, are often used with aortic insufficiency. If patients are overweight, we encourage them to get weight down as well, because the heavier they are, the more blood is pumped out and the more recoil there is pushing the blood backwards. Once we notice that the heart is stretched out beyond a certain limit, and the normal heart, when it squeezes and relaxes, once it's squeezed, an upper limit of normal diameter of the left ventricle, or if you look at an echo report, we call it an left ventricular end systolic diameter, is up to 3.5 centimeters. Once that gets to 5 centimeters, at that point we should start thinking about replacing the either repairing or replacing the aortic valve, but it's usually a replacement for the aortic valve. Once that's over 5.5 centimeters, that becomes a much more urgent situation. So those are numbers that need to be followed on echoes. There's no way with a stethoscope to estimate what those numbers are going to be. So it's very important for those patients to get regular follow-up. This is something that changes over time, so sometimes patients say, I want an echo every 3 months. They don't need echoes every 3 months, but waiting every 5 years between echoes, once the ventricle starts to dilate, is much too long. In anywhere between a 1 and 3 year window, depending on the extent of the aortic insufficiency and the size of the left ventricle, will be a reasonable window to repeat echoes, which also stands for ultrasound, to determine the size of the left ventricle. When it comes to replacing the valve or repairing it, aortic valves tend not to repair well, so we usually replace them. More valves are getting replaced now through an IV without having to do surgery. The problem with a leaky aortic valve is it's difficult to put in a new valve when there's no calcification on the valve and get it to anchor where it's supposed to be. So unfortunately at this point, which I'm recording this now in the summer of 2023, for patients with purely aortic insufficiency, it's usually a surgical replacement, not a replacement that we can do through an IV. We're working on trials to get valves which anchor well enough for aortic valves that leak, that aren't calcified, and hopefully within the next 2 to 3 years, we'll be able to replace those valves without having to do surgery in the majority of patients as well, but we're just not there at this point in time. I hope you enjoyed this video. If you have questions, reach out anytime.